Excellent. All right, welcome everybody to the National Care Coordination Academy. I am super excited for today. Thank you all for helping us prepare for our team presentation day. You guys have done some excellent work and really excited to see everything in action. Erica, you can go to the next slide. So just some welcome and housekeeping notes. Today's meeting, as you know, is being recorded. And then we're actually also going to record the breakout rooms. Given you guys have done such amazing presentations and we're going to have you all split into different groups, I want everyone to be able to see as many presentations as possible. So we will record the breakout groups and they will be uploaded to our Open Pediatric platform for you to view later. If possible, please try to not put us on speakerphone or put us on hold. And we ask that you stay muted during the session until we get to questions and answers in the group discussion portion, where then we will definitely encourage that you unmute and speak. Today, we are asking that you rename yourself to include your group number. So you'll see on the bottom corner, I would love for you to please put group 1, 2, or 3, and then your name. You do not need to put your state abbreviation today, as we're going to mix you guys all up. So please take a moment to put your group number first and then your name after. The chat will be moderated today. We encourage your questions and comments to be put into the chat. We will be separated out into our 3 groups, and that will all have individual chat rooms in there as well. And there'll be plenty of time for questions and answers. And if you are using a phone with your computer, please try to link them so we just have one person that we'd be able to move to the breakout groups. Erica, you can go to the next slide, please. So just to show you how to rename yourself to include your group number, if you go down to the participant area at the bottom of your screen, and then it will scroll up with all the participants. If you find your name and you right click and you hit rename, you're then going to be given the option to free type in what your new name should be. And please be sure to identify yourself with the group that you'll be going to for your team breakouts. And you can go to the next slide, please, Erica. So I think someone already just asked in the group to be reminded of the description of each group. So here you go. So for group 1 is our funding sustainability group. The teams that will be presenting in group 1, and this is the order of the suggested presentations, will be Team Texas, Team Florida, and Team Indiana. Group 2 is our care model group. The teams presenting there will be Montana, Minnesota, Kentucky, and New Jersey. And then group 3 is measurement. We have our 2 spina bifida teams, Spina bifida Hershey, Spina bifida Cincinnati, Michigan, and California. Please note, if you are not presenting, then do not follow your team. If you're not presenting, you should be going to a group that is different from the one your team is presenting in. So for example, if I'm presenting for Team Texas, if I'm not presenting there, I'm going to go to either the care model group or the measurement group. Only the presenters for the team should go to the one that's identified here. Your team leads should have told you which group they would like you to go to. If for some reason you're not sure, when we get to the breakout groups, we can happily move you to either one that's opposite from where your team's presenting. If you're a student or an observer with us today, welcome. We're very excited to have you. You are welcome to go to any group that you wish, and you do not have to have a specific assignment. So you can let us know where you'd like to go. I'm happy to put you there. You can go to the next slide, please, Erica. So as a reminder, we offer continuing education credits for every academy session. We are approved to offer credits to RNs, NPs, MDs, PAs, and social workers. To be able to obtain your credit, you must do the following. We'll have you put your information on the attendance Google Doc. I will share this in the chat in just a few, and then we will also share it at the end of the session, and I will email it out later. At the end of today, we will share the evaluation in the chat that you must also complete. Once you've put your name on the attendance sheet and you've completed the evaluation, we will send a message to our Boston Children's CME department that will include your information. And within about 2 to 3 weeks, you'll receive another email from them with a brief survey to complete. And they will give you instructions for how to access your transcript, and they will be able to print your certificate. For anyone that might not be here today that's on your team that maybe wants to watch the recording, if they are one of the approved professions, they can still request continuing education credits for up to 6 weeks after the live event. You can go to the next slide, please, Erica. Awesome. So today's agenda, super exciting day. So we're already in the beginning part to welcome and opening remarks. At 12:10, We're gonna, maybe a little bit later, we'll have a few more slides, but about 12:10 to 12:15, we're gonna give some time to travel to the virtual groups. We'll go through the self-selecting option, and most of you are pre-assigned, but just in case, we wanna make sure everyone gets to where they need to go. We'll then have an hour and a half for the team breakouts with the team presentations. After that, we will take a short 10-minute break before we dive into the group discussion. We'll spend the majority of the afternoon talking about what you learned and how the presentations went. Then we'll end the day with giving you some next steps and highlights for upcoming events. You can go to the next slide, please, Erica, and then I'm going to hand things off to Rich.
Thank you, Heather, Erica, Jessica. I want to just begin by thanking you guys for the tremendous amount of effort that you've always put in, but in particular for today's really re-engineered approach to the Academy. So sincere thanks to all three of you. Meg and I want to welcome everybody to this session. I have the privilege of, I'm actually going to read this acknowledgement. We're mindful that in this time between Indigenous Peoples Day and Thanksgiving, we want to recognize and commit to responding to past injustice. This includes work we can and should be doing in this Care Coordination Academy. This might include formulating partnerships which actively give voice to and solicit experience from Indigenous communities and all marginalized communities to inform our collective efforts to equitably, meaningfully, sustainably, and effectively address the needs of families from these diverse communities. Next slide, please. These are the learning objectives for today's session. Understand approaches by other state teams, including successes and challenges, and be able to apply relevant knowledge to your own efforts. Develop relationships with other state teams that advance priorities of sustainable care coordination, and identify ways to sustain projects beyond participation in this Care Coordination Academy. So we want you to learn from each other. So what is the path ahead? As in politics, all efforts to implement care coordination is local, but this national scope Care Coordination Academy suggests that there are key elements that are universal. We want to build on those, and we want to give agency to the various teams to be able to do what they need to do in that local environment. There are critically important elements: patients and families as partners, planning partners, not reactive partners, planning and implementation and measurement and ongoing promotion. And outcome, equity and value being critical outcomes in order to advance our cause. Next.
I think this is mine. Hi, everybody, and welcome back. I am thrilled to see the attendance here. I want to acknowledge something that we've, as a leadership team, spent some time talking about, which is that we have this session and 3 more. And we want to very much make sure that these programs are sustainable in your communities. And we know that everybody's going to be left off at some point. But I think I want to just tell a quick story about a learning academy that we did when I was in Minnesota, and Carolyn Alshouse, my dear friend from Minnesota, was on this with me. But we did this kind of storyboard. It was when we could do it in person. And one of the storyboards, a young mom who was actually still an adolescent at the time of doing this, became the teacher on the storyboard. And I realized that her passion and involvement and understanding made it so that this would be successful, because the learning was coming from the students became the teachers. So today I'm very excited that we're turning to that, and that all of you who have worked so hard and know so much and are so much, quite honestly, more learned than us are moving to be the teachers. And we're looking forward to this session, to hearing the best of what you've done, and to hearing frankly about your challenges and what we can do to support you as this academy progresses over the rest of this year. And turn it back over. I think, Heather, this is for you, right?
Yes, thank you so much. Erica, you can go to the next slide, please. Awesome. So I think some of you know, I like to sneak my son into everything that I do. So with the Academy, he was actually just born. He was only a couple weeks old on day one of the Academy. I had just returned sort of part way to my virtual work. So over on the left, that's him on day one back in September of 2020. And then this is him now. I thought this was a great metaphor to sort of demonstrate your progress. You know, he's now walking and talking and doing all these awesome things and climbing. And it just kind of shows exactly what you guys have been doing. You know, it's only 15 months, but the progress has just been outstanding. And to be able to see in these presentations, all of your challenges that you've overcome, what you've learned, it's been really special to see and have all of this growth with you guys. So I also wanted to share his growth with you as you're doing the same thing. So thank you for allowing me to share him. You can go to the next slide, please. So to remind you all, this is our three-legged stool of sustainability. And this is how we have structured the rest of the day. So to have sustainability, we need to have elements of the care model, measurement, and funding. This is the way that we have identified the three groups today. And teams were selected to present in each group based on what you're currently working on. So as we know, to be successful with sustainability, you need all three of these elements. And so I think all of you are working on all of these very nicely. And some of you have either already accomplished one area and now you're working on the next. And so that is how you are identified for which group you will present in today. You can go to the next slide, please. So when we do go to the group presentations, at the end of the afternoon, we'll come back to have a group discussion. So we wanted to share the discussion questions with you now, so you can be thinking about them when you're in the team presentations. What we want you to be thinking about is, you know, of course, what did you learn? Was there anything that is going to stick with you? And if so, what team was that from? We want you to be identifying new team friends and new team partners. So what team were you talking with or that were you listening to that really stuck out with you, something that they're doing or a challenge that they overcome? So start thinking about that. And then we also want you to think about what strategy and what tactics will you or might you apply to your program based on what you learned. So keep these in mind. We'll throw them in the chat before we head over to our breakout groups, but then we will remind you of these when we come back for the group discussion. You can go to the next slide, please, Erica. So just reminding you again, we're going to get ready to head over to breakout groups, but these are going to be our teams. The order that you see up here is the order of recommended presenting. Jeff Schiff will be the facilitator for the funding sustainability group. I will be facilitating the care model group, and Rich Antonelli will be facilitating the measurement group. We all have your slides as a backup. So team leads, we encourage you to share so that you can go at your own pace. But if needed, if there's any technical difficulties, we will have your slides as a backup to be able to share for you. Each team, when I had initially emailed you, we dedicated about 10 minutes for presenting and 5 minutes for Q&A. We can extend that a little bit because there are two teams that are not going to present today. So we can have about 10 minutes for team presenting and 10 minutes for Q&A. So about 20 minutes for each team, and then open discussion at the end of the groups, depending on the timing. You can go to the next slide, please, Erica. Great. So I am going to go ahead and open up the breakout rooms. Some of you have been pre-assigned. So as soon as I open up the breakout rooms, you should get a pop-up asking you to head over to your group. If you have not been pre-assigned, you're not sure where to go, that's when you need to write on into the chat, and Erica Norcus and Jessica Flaherty are going to be here to help us manually move people if needed. But you are able to self-select your breakout room. To be able to do that, I haven't opened them yet, so you can't see it just yet, but you would go down to the bottom of your screen and hit breakout rooms, and then the rooms will list, and all you have to do is select which one you want to go to, hit join, and it will bring you over. So let me open up all the rooms. Okay. Eric, you can go to the next slide, please. Excellent. So we're going to be in the breakout rooms until 1:45. I'm going to stay in here for a few minutes with you guys just so we can get everyone over. But Jeff and Rich, feel free to go over. We can either move you manually, but you can look at the bottom where it says breakout rooms and you can select your group to go to. If you need us to move you, I can move you over.
Please move me. I'm not seeing a button to click.
No worries.
Yeah, same here. Sorry.
Okay. All right, Rich, you've been assigned, and Jeff will do you.
Hi, I'm sorry. I know that we coordinated within our org, and I'm actually the only person from my org who's supposed to attend group 1. Is there any way that I can go to group 1 instead of group 2?
Sure.
Okay, thank you.
And that was Audrey Davis, right?
That's me. Yes, I'm getting,
Okay.
but I declined the request to go to group 2, but I'll go to the manual one. Thank you.
You're welcome.
Heather, this is Sierra Smith. I did not get a request to join a breakout room.
Let's see. And Sierra, what team are you from?
The Penn State Hershey. I should be in
Okay.
group 3 as I'm presenting for them today.
Okay. Let's see. And Erica and Jessica, are you able to see the people that need to be moved over to? Because I'm going to move into the care model group in just a minute, but let me move Sierra.
I do.
This is Adenike. I also need to be moved to group 1. Thank you.
Hi, Adenike.
How are you?
Good. How are you?
I'm well. Thank you.
All right. Erica and Jessica, are you guys okay if I head over to the care model group?
Hey, Heather.
Hi.
This is Aldria Futrell from Department of Health. I'm just observing today. Could you put me in group 2? I think I would be interested in seeing that
Yes.
presentation. Thank you.
You're welcome.
It may show Aldria White Futrell. I'm late too. I reserved
No
later.
worries.
Thank you.
You're welcome.
Heather, this is Stephanie Rose with.
Recording, so we have this recorded. Awesome. Okay, so welcome to the care model group. I'm excited to have you all with me today. As most of you know, I'm Heather Pamela. I'm the manager of the academy, and I'm also a pediatric nurse practitioner at Boston Children's Hospital. I work mostly in inpatient neurology and epilepsy, but my background is all in complex care management. And I had helped in a prior role that I was in develop and implement a care coordination program for complex care in an adolescent and young adult practice. So elements of a successful care model is what we're really going to talk about today and listen to all of your presentations. The reason you were identified to present in this group is that when reviewing your presentations, it really looks like you are focusing right now on elements of the care model or already sort of mastered it a bit. And so we wanted you to be able to present to the group today. In this group, we should have the presenters of teams, which I'll show the list in just a moment, but also should have a mix of some other teams as well. And so elements of a successful care model, not limited to these, but important are going to be that it meets the needs of your population. The care model is sustainable, it's measurable, it includes patient and family voices in the development and the ongoing part. If there's things that aren't working well, always getting input from your patients and families, and it should be equitable. We talked about this just before we went, but I wanted to remind you of the discussion questions. So when we get back to being in the big group, some of the things we want you to be thinking about when you're listening to this today is what did you learn? What parts of the team presentations have stuck with you? And trying to remember which team you heard what from. And then if there are any strategies and tactics that you learned from hearing the presentations today, and are you thinking about applying them to your program and how would you do so? So the order of presentations today, I have Montana up first. I just want to make sure, do I have someone here available from Montana? I want to make sure everyone's in the spot. If you want to just unmute and you can let me know if you're here.
Yes, I'm here.
Oh, Mackenzie, you're there, right?
Yes, can you hear me?
I can't hear you.
Oh, let me change my
Can you
audio.
guys hear her?
I can hear her.
Okay, then it's me then. Hang on.
Yes. Good.
There you go. Mackenzie, can you speak again so I can make sure I can hear you?
Hello.
Perfect. Thank you. Okay, so we'll have Montana and then Minnesota. I see Rhonda. You're here. Perfect. Kentucky, I see Ivy. Hello. And then New Jersey, do I have Steve? Anyone from New Jersey to present today? Not yet. All right, we'll see if he joins later on, but it works out good because he is in order to present last. Okay, so we will have dedicated time for questions and answers after each team presents. I have inserted a little Q&A slide. I'm going to encourage that you put your questions and comments into the chat, and then I can go ahead and go through them at the end when we have the time. But I also encourage you to unmute and talk when we get to the Q&A portion. I'm going to try to keep the questions and comments once the teams have presented and we get to the Q&A part, just to avoid interruption, but definitely encourage discussion today. And then we're going to have Montana start to present. Mackenzie, I have your slides here as a backup, but I'm going to allow you to share. That way you can go at your own pace, but if any technical difficulties, I can pull them up.
Great, thank you. Well, let me work on sharing my screen right now. Can y'all see that? Can y'all see my screen right now? Perfect.
And I'm going to put a timer on my phone, not to make anyone feel rushed, but just to make sure that we get to everybody. It's going to be 10 minutes of presenting and then 10 minutes of Q&A. We can be a little flexible though, because this group was originally going to have 5 teams, so I think we'll be okay. But just in case you hear my phone beep.
Okay, sounds great.
You can go ahead.
Oh, sorry. All right. Hi, everyone. So my name is Mackenzie Peterson. I'm one of the co-leads for the Montana Care Coordination team. I'm the CoIIN director in our state, and I work with the Department of Public Health and Human Services. I've been in my role since end of September. And then Kim Brown is our other co-lead, as she works with the University of Montana's Rural Institute for Inclusive Communities. And then we also have Ali Rive, who is our AmeriCorps Vista, who's been providing support. And as part of our team, we also have over 30 different stakeholders who are involved. And I'll get into a little bit more detail on that in the next slide, because I think that's partly what makes Montana's team so unique. So we are focused on engaging different partners on a care model. So we were not invited to join this group because we are experts on the care model. We are very much in the beginning stages. So for some context setting, Montana is a fee-for-service state still. We don't have managed care. And Montana is a frontier state. We're one of 3 frontier states. As well as Wyoming and Alaska, meaning we are very, very rural. Our biggest city is 110,000, and that city is 5 hours away from our capital, which is where our state government sits, which is a town of 35,000. We have, I think, 3 cities over 100,000. I'm appreciating the faces some of y'all are making because we are very small. And I think that kind of speaks to where we're at in terms of really focusing our work on trying to build community and build sort of consensus between our various stakeholders. So we have over 30 folks who are engaged at various levels with our group. I began as co-lead, myself and Kim Brown, back in January. So the Care Coordination Academy wasn't, we weren't part of the original group engaged in bringing this to the state and setting the ground level for what our goals are and how we participate. So it's been a little bit of a learning curve as both me and Kim have tried to work with our diverse stakeholders to find some common ground. Folks engaged in the academy include Medicaid representatives, but fairly not the decision-making Medicaid representatives, unfortunately. So not our Medicaid directors or administrators, but we have subject matter experts on how Medicaid works for primary care and care coordination. We also have Blue Cross Blue Shield as a payer involved. We have a university center, so the Rural Institute for Inclusive Communities, including some of their researchers, participate. We have various public health participants. One of them supports our referral resource connection system. We also have providers. So we have some doctors and some nurse care coordinators. We also have families. We have our family HRSA delegate, as well as participants from our Family to Family Health Information Center. We also have some involvement from our School Nurse Association, and we've just been kind of expanding and growing our list. But of those 30 folks who were part of the original team who were invited to join this academy, we have about 10 or so consistent contributors, which really is centered around our parent leaders, public health, and our Rural Institute for Inclusive Communities. So what we've been doing is trying to build a base for information exchange, as each of our stakeholders is coming from with a very different perspective and very different knowledge levels on how Medicaid works and what the status of care coordination is and what the needs of our families are for care coordination in our state. So in terms of successes, I think our biggest success we've had, and I have to give a shout out to Linda Starnes, who is on this call right now, who really facilitated and helped us with this. But we recently did a Grand Rounds family panel. So with the help of Linda, who was facilitator, and with one of our providers who's part of the Care Coordination Academy, Dr. Notario, who runs our only complex care coordination program in the state out of our biggest city, and it's just located in that city. And with 3 really fabulous parent leaders in our state, we put together a panel that presented the perspectives of families in terms of what they need from the hospital system, what worked for them, what didn't work for them, how doctors can best approach them and their kids, and really just help kind of shine a light for providers on the impact they have in every encounter on the families they serve, and gave them some really critical thinking points around how they can improve their practice and improve the way they engage with the families themselves, like the parents and guardians, as well as the children that they serve. So we did this panel just last month with our care coordination team, and we had, I want to say 40 or 50 participants, which is larger than our core group and larger than our actual attendance list. And then we also presented with one of our university centers, the University of Montana, which holds a regular Friday medical conference. And that medical conference typically has an audience of over 100 providers. Some attend live, most attend recordings. And so we were able to have a pretty broad and wide audience. So this panel was very successful in that we've already received some good feedback, and immediately following that meeting, I had a different meeting in terms of the impact in a small state and how everyone's connected around a grant that's looking to map out our early identification system. And she was in attendance at that meeting and referenced it 3 times in terms of how it impacted her framework and her thinking about some of the common themes in parents' experiences and what sort of lenses she needs to use as they work on mapping out and working with families to care map out their early identification system in Montana, which is still a work in progress, as we don't necessarily have a consistent or consistently articulated early identification system in our state. I think another success of this, of our group, is that we are getting together folks who don't typically meet. You know, our Medicaid system here, it's fee for service, as mentioned, and it's really dense, both in terms of the information that is provided and the limited number of staff who support that program. So it's really a big boon and benefit when we can get someone from Medicaid describing what it means to try to pay for care coordination or sort of allied services within our fee-for-service model within FQHCs and things like that. So it's been a really great space where we've had panels that have presented on the complex care program out in Billings, on what Medicaid is, and how billing works, on what our resource and referral systems are, on what some of our parent support programs are out there, led by our Family Center and a parent peer program we support. So it's been successful to share information, and our goal really as a group is to kind of prime the pump so that when and if the opportunities arise to do things like, let's say, apply for the ACEs Medicaid SPA, we have a group of informed stakeholders who already have connections with each other, who can then work in coordination to act on that opportunity. We're not there yet, an opportunity is not there, but we're trying to be ready for that. And so in terms of some of the challenges, as you see here, I've already mentioned how we've had some turnover in leads, and we have a very diverse group that we work with, and there's both pros and cons to that. And so I think our biggest challenge is leading it is really just trying to figure out how can we get folks on the same page, which is why we started transitioning to this model of sharing information and presenting on different resources and strategies across the state, because we're such a big state with such low population, and we have a tendency to really isolate within our cities and towns. So what happens in Billings is not known in Kalispell, which is like 9-10 hours away. So it's really important that we share information and have a space where we can connect. And some of our priorities and goals I've touched upon here, but it's really about trying to figure out who our key stakeholders are in terms of next steps. Who else do we need to engage in this work of trying to build consensus and collaboration? Who is not already there? So we're thinking about that in terms of a way forward as this Care Coordination Academy ends in May. We're trying to figure out how do we continue this work of engaging our stakeholders and building this common ground and space to work from beyond May. We're also thinking about, in terms of our partnership with the Rural Institute for Inclusive Communities, is how do we, in that light of priming the pump, how do we get education? How do we get common knowledge outside of just these meetings? So how do we get white papers? How do we get common education that all our stakeholders, providers, and families can use? So I think we all know when we talk about, needing to develop a care coordination model and funding a care coordination model, the levers are really at, our governor's office, at our legislator's office, and that's not a space that state employees can work in. But thinking about how do we have partners who can support education and support getting the information out there around what is needed, what our current gaps are, and some ways forward. We're also really trying to focus on continuing to expand family voice and provider voice. We have had, as part of our challenges, provider voice kind of drop out over the past 12 months. So we're really trying to think critically around how to best engage them. We floated ideas around, pilot projects and things like that, but we're really seeing capacity issues, both in personnel and resources, that we can kind of pull towards doing something like that, which would be a space we think we could successfully engage providers when and if we have those funding opportunities. So I think that was my 9 or 10 minutes there. Any questions? Montana is pretty unique in terms of how we come to this academy, because I know it's one of those spaces. I'm from Oregon, and it always kind of blows my mind because I know how things can be in some states versus where we are in Montana. We're a little bit behind the curve. And so, I'd always love to hear feedback or other states who have sort of gotten to where we need to go, as particularly states have also worked in really rural populations. I know every state has the rural populations they serve. And I think how to successfully serve families in communities where, just the reality of where you live is that, you're driving 2 hours away to see a doctor. And that's a primary care doctor, and not necessarily your specialist, because a lot of our kids have to see specialists outside of the state. And our bordering states are also all fairly rural. We have Wyoming, the Dakotas, and Idaho. So we're looking at families who have, there's a lot of challenges that we're working through, I guess I should say. So I'd love to hear any questions or feedbacks or comments or feedback on how you successfully engage diverse stakeholders to try to level information sharing in your state to get everyone on the same page.
Thank you so much, Mackenzie. That was awesome. And you had 17 seconds to spare, so perfect timing. If anyone has questions or comments or anything for Mackenzie, now is the time to jump on. I have a couple of questions, but I would love to hear from everybody else, and then I can ask some of mine. So feel free to unmute and jump on.
This is Rhonda from Minnesota. I just think it's so cool that you're doing this from the ground up and statewide. My question for you is the outreach to the physicians across the state. That's something, so I'm from actually a hospital system that we used to provide within our system, but then kind of dropped it. And providing it, so Mackenzie, are you from state government?
Yes. Yeah, we're
okay.
In the health department. I'm the Schindler.
Okay. Then I'm wondering, where the education should come from so that it reaches as many people as possible.
Yeah, and we have some limitations here in my role. And so I think that's where working with our partners, like working with the Rural Institute, which, university centers also have some limitations, but they have a different hierarchy and leadership structure where I think they have a bit more freedom. We also are, our Family to Family Health Information Center is located within our Rural Institute for Inclusive Communities. So they have that family lens and better leadership at their leadership table, which also includes researchers and other programs that serve the population. So I think they're really our best vehicle for getting information out that is both, the best information out, research-based as well as family-driven.
Awesome. Does anyone else have any questions for Mackenzie or any comments about her presentation? I'm going to jump in with a question, Mackenzie. I'm just curious, you had mentioned about the development of an early identification system. Can you, I know it's being developed, but can you speak to a little bit like how is it being developed? What types of like elements are they using to try for this early identification? And is the goal of this early identification to find kids that are specifically in need for care coordination and integration services?
I believe so. I'm not leading that grant, but it's led by our Rural Institute for Inclusive Communities, who's part of this Care Coordination Academy, and we've had 2 different stakeholder meetings. And so at this point, they're looking at mapping out the system. So I believe they're going to be working with some families to do some care mapping, as well as they've been having meetings with myself and other key stakeholders like Part C, WIC, Head Start, maternal child health, all those home visiting, all those key players, because we don't have, like, I couldn't give you an elevator pitch on what our system looks like. And I think everyone would give a really different definition of how you enter the system. And at the same time that work is happening, we're also using some ARPA funding through Part C, and we work with Part C fairly regularly to try to improve our child find services. So I think we're at a kind of exciting place because in our state, about a year ago, we created a division on early childhood and family services. And so now we have all our childcare, Part C, Head Start, Children's Trust Fund, child abuse prevention, as well as all our like child and community family health services all within one division. So it's offering some opportunities to partner better. And COVID happened, so we're now just finally at the space, particularly some ARPA money, to start talking a bit more about like what that could look like and how we can strategically partner.
That's awesome. Thank you. And then I saw Ivy. I actually had a similar question to Ivy too. So Ivy Goldstein had said regarding the grand rounds, was that something Title V or the health department organized? Was it the hospital? She loves the idea. She has not seen a parent panel at grand rounds, but see how it can be so impactful for providers. I totally echo that. I was going to say something similar. Working in a big hospital setting myself, the majority of grand rounds that we see are all providers, and we have people from all over the country, but to actually have a parent or family panel must have been really impactful. Can you explain a little bit more about how that was organized?
Yeah, like I said, I have to give major kudos to Linda. She facilitated and helped us do this because this is the first time we've ever done anything like this. So it was really the Vista on my team who helped do a lot of the logistical organizing of it. And it was a partnership with the Rural Institute who reached out. I think at the initiation of this Care Coordination Academy, reached out to University of Montana, who holds the grand rounds, to get us basically slotted on their calendar. And it's the first time they've ever done anything similar. So we're really hoping that, because in some of the communication that we had with them, there's a little bit of like, wait, how is this really like, clinical, or how, like what really is going to be the benefit to providers? So we're really hoping that it went well enough that they'll see the benefit and invite us back. I mean, we're going to pursue being invited back. Hopefully in the next 6 months to 12 months, we can get a kind of a regular cadence on their schedule. But it was the first time we did it. I think working closely with the Family Information Center, and we did an application process through them to try to solicit and identify families who could speak to diversity within their perspectives as parents, and the experiences that their kids have had. And as this was the first time we've done it, so I'd be happy, Linda, if you have anything you want to add. Linda facilitated it for us, which I think was critical to its success as well, because we were newbies in this area, and Linda's not.
Well, and I was just going to say, if there was anybody that was going to give a shout out, it was an extraordinary experience for me to be a part of this group. The folks in Montana were extraordinary in their development of this program in a very thoughtful way. And the families that were represented on the panel it was this interesting thing that we families find is the common threads of our each and individual unique journeys in complex care. And so I would say the reason that I was so pleased to do this is because my son, who is in the room with us, Max Starnes, and I had a chance to do a grand rounds with Orlando Health Systems and our team leader, Dr. Farias, a couple of years ago, and it was focused on healthcare transition. So Mackenzie, I'm going to say I would hope that that would be one of the presentations along with just general care coordination, but then a focus on healthcare transition. There's so many topics that families can inform on. But it was a terrific outing. And I would highly recommend any of you all, if you have this opportunity to explore doing this, and maybe Mackenzie, Allie could, and you all could provide a kind of the template for the planning and development and presentation of that. And that would be a nice sharing for the whole academy, I would think.
I was going to ask that. Yeah, that would be awesome to be able to share that. This is exactly the kind of stuff that we're looking for. And to be able to have a family, voice that helps structure it and really pull it together is exactly, because you don't want providers planning this. You really want the families to be able to plan this.
But the nice piece was that there was a provider as well who spoke on the front end and then kind of tied the bow on the back end with her perspectives of all that was shared. And I will say that I'm utilizing this in my own state with my Title V group to say we need to figure out how we can pull together some kind of statewide conversation and in this way as well. So Montana has inspired Florida.
Oh, that's good to hear. Well, Linda was just incredible asset to getting this all off the ground, and we will certainly be happy to put together a template. And another space this is taking us to in terms of topics is, a lot of our stakeholders are also from like state systems like Medicaid and public health. So we also want to do one with not a provider audience, but like a state employee audience where they can think about, because I know often when we talk with Medicaid, it can be very policy driven discussions. And so we want to have a conversation around like, really, what does it mean for getting that information in a way to families where they can understand and consume it, and what is like the impact of their work on families. So we're hoping to also have one that has more kind of a Medicaid public health focus as well that we can direct towards our state staff. Okay.
Excellent. Thank you so much, Mackenzie and Team Montana. That was an excellent presentation, and we really look forward to being able to see the template for a family panel. Next up is going to be Rhonda and Team Minnesota. Let's see. I think Mackenzie, we'll have you stop screen sharing, and then we'll switch over to Rhonda.
Yeah, I'm trying to find it. Oh, it's on my other screen. I have 3 screens. Sorry.
3 screens. I love it.
There we go.
Okay. Can you guys see that?
Yes.
Yep. Okay. Let me just bring it up so I can change this here. Okay. So I literally took Heather's directions to heart when she said, first slide, you list your team. This is everybody on our team, not the folks that are just in this room. So, but, honestly, when we joined the Care Coordination Academy, this is our 2nd year, I was so excited because it allowed us to pull in not only key players from our organization outside of clinical care, but also key players across the state. So we've got a Medicaid person. Nicole is our state person, Title V person, and then all the parent advisors, and then all the clinical folks. There we go. So what we're working on, again, just to preface this, so Montana and I think New Jersey, you might be new to this, we've been participants in the CoIIN project since 2018. So, but our complex care program is brand spanking new. It started in 2016. So even though it's been 5 years, it's grown exponentially. And some of our biggest challenges have been because of that growth, in that our infrastructure hasn't kept up with the number of enrollees in the program. But as participants in the CoIIN project, a requirement was our team must include family advisors. And the CoIIN project was very helpful in identifying those advisors, training those providers, those advisors and supporting those advisors, which was great. Now that we're kind of on that with our own, we're struggling with that, in that we need to develop a program to make that piece sustainable. And then we're also trying to increase basically the diversity of our parent representation, and I'll speak about that a little more. From a measurement perspective, I feel like we're in a pretty good place. For the last 2 years, again, as part of the CoIIN project, we were collecting a parent perception survey. But to be perfectly honest, it really didn't fit our complex care program that well. We're not primary care. We're part of we're a specialty health system, and this is a specialty program. So with the ending of that and joining the Care Coordination Academy, we're going to be starting a new survey. We actually took questions from both the PIC survey and the FECC survey that speak to the elements that the program either currently provides or plans on providing in the future. And we modeled that against the new Children and Youth with Special Needs Care Coordination Standards, so that we're providing best practice care coordination and then measuring, is it actually happening? And then we're also going to do a time study, but not only of provider, the clinical people, but we're also going to be working with parents to track that information. Because there's really no good data on how much time and the specifics of that time that parents are spending on care coordination. We know it's a ton. And are there things that the system could do to support that? A lot of it, maybe not, but just knowing what parents are doing will help us better develop the program. And then for funding, we're looking to both internally, funding to increase our leadership. And we're also working on a pilot program, and we'll be doing an ask to the Minnesota State Legislature for that. But that's a very high level at this point. So our successes, again, are just, we've got a really, really good relationship with Family Voices, with our Title V people and our Medicaid people. And, my third bullet, we've evolved in our approach to diversify family advisors. So in early March of 2020, so we recognized the fact that we didn't have all of our family advisors, and this was done purposefully initially, are English speaking. And it was so we could get things started. And then the goal was within a year and a half, we would start bringing in some of because we serve a very large population of Somali parents and families. So we would pull in some Somali speaking families. Well, when it came down to it, in talking with our Family Voices folks, and we spoke with a gentleman from Family Voices National, just having one parent trying to represent a culture might not be the best way to do it. And so he suggested starting with some focus groups, and we were in the process of planning that, and then COVID hit, and we kind of dropped everything. However, so then we kind of went back to, well, we need to get some diversity here. So let's just bring some parents in. And we were almost to that point about 2-3 weeks ago, and we put the brakes on it again. It's no, just because a parent says, oh yeah, I think I can do that. And we actually asked our clinicians to recommend some bilingual families. Again, we thought, what, the way we got our current parent advisors, one of the techniques was we held just a general focus group at the start of our participation in the CoIIN project. And at the end of that focus group, parents were given my contact information if they would be interested in learning more about some of the parent advisor roles. So we're hoping to do a similar thing with our Somali families and Spanish speaking families. So we'll kind of see how that goes. And probably my biggest recommendation to other teams, just be patient. I honestly, with the CoIIN project, we were the infants in the room. when we started participation because our program was so new, and it seemed like everybody else was light years ahead of us. And Kentucky team, you guys were kind of in the same boat. And it seems like, after those 3.5 years, we're finally starting to gel and actually get some momentum. It takes a lot of time. So don't lose hope. Challenges, okay. Until McKinsey started talking, I'm like, oh, Minnesota, our demographics, geographic stuff is so difficult. Yeah, not as bad as Montana, but ours is a little different. So this right here, this is what's referred to as the 7-county metro area. Over half the population of Minnesota lives here. The rest is spread out all across. And seriously, if you're coming from up here or up here, it's a good 5-6 hours away. And so we have patients that live across the state or even in the bordering states, the Dakotas, Iowa. And our silver lining with COVID was it forced us to move to telehealth, made things a whole lot easier for parents. But it's still, our biggest challenge is identifying resources for these families in very, how can I say, resource scarce areas. It's really hard. It's really hard. So that is probably one of our biggest challenges. The other is transition. Linda, you mentioned that, and we're actually working on a separate project with that. It's just, we have a really hard time finding adult primary care providers. That is the biggest challenge. It's just tough. It's really tough. The other is equitable provision of care coordination. So at Gillette, all patients are complex because we're a specialty clinic. And those that are seen in the complex care clinic are the most complex of complex. I mean, because our personnel doesn't match the number of enrollees, both clinicians and families feel guilty because they're not providing the same level of service to everybody, because they just can't. So that is a real challenge that we're working to address. Priorities and goal are kind of similar to what I've already talked about. So I'm not sure how I'm doing for time, Heather. But probably our biggest thing, what I want to do is, the reason we're doing the time studies about the clinicians and the parents is to build a business case for better care coordination reimbursement. That's the bottom line. Our providers are not getting reimbursed for it. Our nurses certainly don't get reimbursed for it. And our parents don't get reimbursed for it. And they do a lot of work. And then another thing on our really high on our wish list is to build a business case for parent navigator. And I'm hoping through the parent survey that'll help with that. If we are having a parent as part of the clinic, I know Texas currently does that. There's a couple of CoIIN teams. Just makes a big difference. And that's the end.
Thank you so much, Rhonda. That was awesome. Does anyone have any questions or comments on Rhonda and Team Minnesota's work that they've done?
And I know there's a couple members of Team Minnesota. If you guys have anything to chime in, please do.
Rhonda, you did a great job speaking for us.
She always does.
This is Nick Claxton in Philadelphia. I have a question. I know you said that you deliberately made the decision to start with English-speaking parent advocates in the first place. Can you just explain why you made that decision?
So I don't hear well, Nick, so I'm just going to rephrase your question, make sure I understood. So when I mentioned that it was a purposeful decision to only have English-speaking parent advisors, but I didn't hear the last bit. Kari, maybe if you could fill me in.
Yeah. Why did you make that decision?
Oh, why did we? I hate so a couple reasons, and I'm going to be full disclosure. It was the easy route to take, it's not a valid reason. But the other one was our, I think Trisha who worked at Family Voices at the time, because we were working closely with Family Voices, they were having a really hard time finding non-English speaking parents just to be for their peer support program. And they just didn't have a real good handle on who do we recruit from. So Trisha, I'll let you maybe speak to that a little bit.
Sure. And can everyone hear me okay?
Yep.
So, that was part of it. Nick, another big part of it was explaining or really communicating to the larger hospital system that just having an interpreter is not sufficient. That is not, you can't just have an interpreter and say, oh, this is engaging the Somali community in this process. It's much more than that. And I think we were very mindful that so the complex care program at Gillette is really great at meaningful engagement of families. It's meaningful. We're not wasting our time by being there. We are truly influencing a system, and we are regarded as experts. And I think that, in a nutshell, what I want to say is that just having an interpreter for a Somali family leader was not meaningful engagement. And so we wanted to be purposeful and thoughtful about how we can truly engage those families and really get a good perspective from those families. Does that make sense?
Partially, I would say.
I think we're open to any suggestions as well, because we have struggled with this, and it's something we know is a challenge, and really truly kind of one of the deficiencies of what we're doing, if you have to label it that way. So I'm open to suggestions, and I think our team would feel the exact same way.
Thanks, Trisha. Yes. Go ahead, Nick.
Well, hang on, I'll put myself on. Yeah, I agree completely that just having one representative from the Somali community, for example, certainly does not represent the Somali community any more than one white person would represent all white people, one black person would represent all black, et cetera, et cetera. So that, it would seem to me that, and again, it's not, none of this is easy, but trying to find an entree into the Somali community as a first step, or even in parallel with starting some of the other work, and whether that be through a religious organization, a trusted community agency that serves the Somali population, of which I'm sure there must be some, if not many, given the fact that the Somalis have been in Minnesota for several years now, that might be a way to go, rather than having just the proverbial token Somali and then one interpreter and saying, okay, we've covered our diversity. So that's just one thought, and I'm sure other people have better thoughts than that, but thank you for answering.
Oh, thank you.
Thank you, Nick. And I want to just add one more thing. Those are all avenues that we are pursuing and building a relationship with, because we've learned that you need to build a relationship with families. You can't just, hey, come on in and give us your opinion. That's not true engagement. So, that's part of it. And we also have looked beyond the idea of just adding someone to the quality improvement team as a family advisor. So we're really looking at the best ways to engage with families from certain communities in a way that works for them. so that they feel comfortable, trust the process, and can really help us design a system that's going to meet their needs.
Cool. Thank you.
So one other thing I wanted to toss in. Oh, Stephen, go ahead. Maybe not. With COVID, our team meetings obviously flipped to virtual. I will never go back to in-person. Because I can't hear worth a darn, and it's easier for me to Bluetooth the sound to my hearing aids. So that's one thing personally, but more importantly, it made the meetings equitable for the parent advisors and the clinicians. Because a lot of times parents at the last minute, you can't show up to a meeting. And so they would have to join remotely by phone, and it is not even close to being the same. Whereas when everybody joins virtually, it's a very equal platform.
Rhonda, that kind of builds on a question that I was going to ask. This kind of is to you and then also Montana a bit. So being from myself from Boston, I am spoiled with the resources and the locations. We have so many different hospitals available and everything's here. I'm just curious with the geographical challenges that you guys face. How do you overcome those? You know, I know pre-COVID, it was a lot less virtual opportunities. Now I imagine the virtual world has been helpful. But if a child does need to see a specialist and that specialist is 6 or so hours away, do you help coordinate transportation, or like kind of what does that look like to kind of overcome some of these challenges?
All right, I'm going to let you answer that one because you put a
Yes. So yes, and we have our social workers and care managers will help proactively with transportation and coordinating. Some families want to pile, they want to drive 6 hours and do all of their appointments in one day. Some say we want to space it out, and then we work through how do we get lodging while they're here. But another avenue and more meaningful avenue is how do we help families thrive in their home community without needing to come to St. Paul for everything. And so we have a long ways to go in that, but right now we do have some smaller pop-up locations for Gillette closer to those areas, so we can get some of our specialties up there and do coordination with that group. And then truly partnering with primary care providers and larger hospital systems that are closer to kind of manage some of those more basic general medical needs, so that they can just leverage coming to St. Paul for that specialty care. But we definitely have a long ways to go. And like Rhonda said, the virtual piece has been a huge benefit and has kind of decreased the amount of times families have to come to St. Paul.
No, we did not, Nick. I like that. Yes, if we provided dog sleds.
I'd say for Montana, it's definitely a big struggle. We offer some financial support to families, and it's been used for reimbursement. For example, we had a family that was at one of our reservations on one side of Glacier National Park and had to get to the other side of Glacier National Park for chemotherapy. And I mean, we don't have a great solution overall, like system wide yet. So our financial systems, we know, can't really support all of that. And then beyond just, that's also reliant on a family member driving someone there, which obviously in the winter, things like that is really hard. Telehealth has advanced. And, with COVID relaxing some of the rules, that's been really helpful because we have dial-up locations still in our state. So not everyone has access to broadband and things like that to really facilitate some forms of telehealth. We also try to do regional clinics. But it's a big issue, and it's a gap. We don't have a great solution, honestly. At this point, we're still working on that.
Well, thank you guys for all of this information. I think we'll jump next to Team Kentucky, and we can hand things over to Ivy Alexander.
All right, hello everybody. I'm going to share my screen. All right, are you seeing the PowerPoint there?
Looks good.
Yes, okay. I see nodding heads. All right, so I'm Ivy Alexander, and I'm the Executive Director here at the Office for Children with Special Healthcare Needs in Kentucky, and I'm also the SHIN Director here in Kentucky. We're part of the Cabinet for Health and Family Services, so it's a little bit structured a little bit differently than some of the other programs, MCH programs. The team members that we have listed are myself, our Medical Director, our Division Director of Clinical and Augmentative Services, and it's our Nurse Service Administrator as well. We have other programs within, we call ourselves OSHIN, but of course, with the Care Coordination Academy, we're focused primarily with the clinical services. And then another key member of our team is Sandra Gilbert. She's the director of our F2F program, and the F2F program is also part of the Office for Children with Special Healthcare Needs. So just to give you some background on what we are doing, we are probably, I don't know if we're the newest addition to the team, but we just started with the Care Coordination Academy in September. So we are brand new. Just to give you a visual of who we are, we have 10 offices, 10 clinical settings across the state. So we offer direct care as well as, of course, care coordination. We have some fabulous nurse care coordinators here in Kentucky. We've been doing this work for several years. And so one of the reasons we're in this academy is to improve. We want to expand basically what we're doing with care coordination, our current model. We're focused primarily on our specialty medical clinics. So we have providers that we contract with. They're primarily from our two major universities, and they go out into the state to our clinical settings and work with our families there to see our patients and then work with the care coordinators. But again, we're so focused on the clinical side of the care coordination. And when you look at a care coordination map and all the care that's required, we do have a goal to expand that out. And one of those areas of expansion, of course, especially with COVID, is the mental health area for children. So that's one of the areas we're looking into expanding into. And we're doing that through partnerships. We have a lot of data. We have a system that was built in-house that houses all of our encounter information. We do hearing screens at birth. And so there's a lot of data that we have. We use that now, but we want to be able to tweak what we have, use the new measurement tools that we're getting from the academy in order to then improve what we're doing with care coordination. So some of our successes. As an agency, patients and families are our driving force. So they are part of our clinical, they're those that we offer care to. They are employees. We have employees, parents who are employed by OSHIN. And then we have individuals with lived experience who are employed by OSHIN. And then also a big part is our family, not our family, but our parent and youth advisory councils. So those two councils each meet quarterly, and we get input from them during those quarterly meetings. And then if there's any type of like strategic planning or anything outside of those quarterly meetings, we get them involved as well. So we always have that family voice as part of what we do. Our care coordinators, again, our nurses that are here, they also see, because they're out there on the front lines and they see the gaps in our state and what's needed. And one of the things, again, with our care coordination, we talk about expanding it, we focus in on our specific specialty, medical specialties right now. So it's not only narrow with clinical, but then also narrow regarding the diagnosis. So we've talked about expanding beyond that as well, those diagnoses. One of the pieces of our database is our care plan. And there's a document that's actually generated at discharge for patients that they can take with them. So that plan is really great, but you'll see that one of our goals, on the next slide, you'll see that we want to actually increase or improve on our shared plan of care. Move to the next slide. So some of our challenges, the first challenge just within the academy itself is we started in September. So we've got time constraint here. So we've got some data we can already work with. We're going to survey across the next few months, and then determine what the needs are, what the gaps are, and what we can improve upon. And in doing all of that, even though we have the time constraint, we also have the same issue that's been brought up previously with staffing and recruiting of staff. So when we have RNs retire, our nurses are retiring, it's been a challenge to fill some of those positions. And then as a state agency, we're just limited anyway in the number of positions, but that staffing has been a challenge. There's plenty of work to do and plenty of need out there, both on the staffing side and for the family side in Kentucky. So, and then again, we've got a nice system now with a care plan that we give out, that we provide, but then also recognizing the improvements that can happen with our current system and truly a good shared plan of care. Those are some of our challenges. And our priorities and goals. So our focus, primarily, we want to make sure that we utilize the data that we have and learn about those new tools, incorporate those tools into what we have now that can guide us with our shared plan of care. Once we get that current data, if we use our current data, essentially, we're gathering new data and we can find those barriers that we need in order to improve the care coordination. And one of the unique things about Kentucky and our program being in the Cabinet for Health and Family Services is one of our sister agencies is actually Medicaid. So being part of Medicaid in meetings with Medicaid, and Medicaid supports us completely in what we do. We have a contract with Medicaid to ensure that the families are getting the services that they need. Children with special health care needs are receiving services. But we know that we can still improve using the national standards, care coordination, and then hopefully we can enhance our reimbursement from Medicaid. So that in a nutshell is Ocean. Do I have any questions?
Thank you so much, Ivy. That was awesome. And yes, you guys are the newest team, but you don't act like it. You fit right on in. So does anyone have any questions about Team Kentucky's model, or any comments about it, or anything similar that you sort of noticed about your own team?
So Ivy, one thing that we've struggled with since, joining the CoIIN project is how to implement that shared plan of care, because our EMR does not support one. So we've tried multiple iterations of Word documents, and it's just so hard and unsustainable. So what are you guys doing?
So we actually have our own developers in-house that can create. Let me say we have 2 developers. So it's not like we have a huge team of people, but we do have our own developers. So the system that we have currently that collects our data and our encounter information, it has our transition information in it. Everything that we do with patients is in this system. And that's where our current care plan is pulled from. Our care plan is there, but then when our kids are discharged, when they turn 21 and leave our program, we can pull various elements from that system and it generates a report. So the shared plan of care can be incorporated into that system. We call it CUP. So if you ever hear CUP, that's our system, Computer Utilization Project.
Oh, I'm jealous. So
we're just 2 developers, and we've got some creative thinkers around here, and we think of new things and, hey, can you do this? Hey, we like this enhancement. So we have been a little bit spoiled in having that. And there are some some things about it that are, you know, it's not an off-the-shelf system. So one of the things that we have to do with that system right now, you know, it's ideal to share information with other providers, to have for other providers to have access to their patient information. So we have a small team, those that actually come to our clinic. It's structured so that they can see that, and it's web-based so they can see it wherever they are. If they need to access that in their own offices, they can do that. But there's still limitations to our system, you know, definitely.
I mean, Ivy, this is Steve Pierce in New Jersey. I think what you're doing is really, it's hard to do, and it's great that you're trying to do it. We just got a grant with Virginia from ACF to try to do a shared care plan that connects all the community agencies in with the practices. So that's it's pretty aspirational, but you know, we're part of the Inc. model, so it kind of fits into that particular approach. But the shared care plans, it makes great sense getting the capacity to have everybody tie into it, have the families, you know, updated and have it be a living document. It does take a lot of work, a lot of technology.
Ivy, do the families have access to that database too, where they can go up and look at it, or does it have to be printed for them, or what's that look like?
So right now it's printed for them, or
Okay.
they can, you know, it could be an electronic copy of it, but they do not have access yet. That's one of the items on the list. Yeah, so currently it's, you know, the Ocean team, the providers, or any provider in that team can see the patient information, but then our care coordinator will download the information for the family.
And it's a live document where anyone can like edit it at any point and it stays, or is it a new one you create each time?
It is, because it uses the data that's in the system. So if, say, it's printed today, but then they see a physician next week and that doctor adds a new diagnosis or something, when it's printed again, it's going to have that updated information in it.
Wow. Okay. That's awesome. I think there's two other questions in the chat. Feel free to jump on if you want. I see Matt Richardson. Do you want to go ahead and ask your question?
Sorry, unstable internet here. Never know what's going to happen. I was wondering, when discussing this shared plan of care, if we're talking across clinical lines and funders lines, like since your Medicaid and CSHCS is apparently co-funded through one process, one agency, are we getting, does the plan of care that the nurses are developing shared with the individuals within a clinical setting, or do clinical setting run their own plan of care?
So this plan of care, and may not, you may have to ask your question again, but it would be shared within the clinical setting. We have not thought through the funders, sharing it with funders. But at this point, it's mainly for the clinical setting, for the families, for the care coordinators, for the providers, essentially, anybody involved in that child's care.
Right. Okay. And the reason I was asking was because what we've experienced is many times the funders have a particular level of detail that they require before saying yes or no to a particular service or piece of equipment, and or trying to convey that to providers of care seeking to have XYZ piece of equipment provided, and whether or not that plan of care carries the level of detail that's needed there or not. That's kind of where I was going with it.
Yeah, that would, it possibly could. So if there's essentially the system that we have is it's a homegrown EHR, essentially. So the information that a provider would put in, and again, you may have to ask your question again, but if we're talking, like, for an example, a physical therapist, if they put in, they make a recommendation for a piece of equipment, all of that data will be in that system. It's not necessarily pulled out in the current care plan, but it's in the system that could be sent. But we have to look into that funding side of things, because there could probably be various versions of a shared plan of care.
Yeah, and as Steve had pointed out, it's very ambitious to get all of those together and getting, community agencies such as mental health and physical health to agree upon elements and whatnot of the plan of care. So I salute your plan. Think it's good. Thank you.
Thank you. I think being part of MCH, the Title V, we're partners with public health, and then also Medicaid. We're all again under that same umbrella, so we're able to coordinate things.
Ivy, there's just one other question in the chat. If you can give an estimate on the number of children that you serve.
We have about 7,000 on the caseload annually. And we do telehealth as well. I know we mentioned the other couple of groups mentioned telehealth. We did telehealth prior to COVID, but really expanded and shifted the model a little bit during COVID.
Thank you so much, Ivy.
Mm-hmm.
And then I think last but not least, we're going to jump over to Team New Jersey. Steve, I can go ahead and pull up your slide.
Yeah, that'd be great. Yeah. And Heather, how much time do I have?
So you're the last one to go. So we have up until 1:45. So we have about 20 minutes. So about 10 minutes to present and then 10 minutes for questions.
Thanks. Yeah, thank you.
Yeah. Let me just pull you up.
And Heather, I came in late, but did anybody else present the ink model yet?
No, you're the first ink.
The first ink. All right, the ink is on. So thanks everybody. So I'm in New Jersey. I'm the PI for this integrated care for kids project, which I'll explain in a minute. But I think many maybe you know about it. It's a model that comes out of the federal government, out of CMMI. It's a very aspirational model, and we've had 2 years to get organized, and we have 5 more years starting in January to actually try it out in New Jersey. There's 7 other states that are also trying out the model, and we've been part of the Care Coordinating Academy from the beginning. They're taking advantage of learning some of the tools and processes that the folks in Boston, et cetera, have been willing to share and work with us about. So why don't we get to the next slide? So as I said, there's a lot of other states involved. This is the slide got messed up in translation. It looks like, sorry for the going from Google to PDF. So anyway, we can go on to the next slide, but it's a Medicaid model. It serves all kids in 0 to 20. In New Jersey, we're trying this out in 2 counties of New Jersey, which is about 140,000 kids. So it's a huge project in that sense. It's a population-based model that states that we have to really touch all these kids at any one time on a regular basis to try to improve their health care and their overall care needs. It's much more than just traditional health metrics. We're looking at not just social determinants, but kindergarten readiness to learn, juvenile justice prevention, out-of-home placements. It's much wider model than only dealing with taking better care of their diabetes or chronic diseases. It's right from the beginning, it's set up to have a partnership council of all the core child service organizations in the area working with us. And we've been doing now for a couple of years now, meeting regularly with all the people from housing, food, mental health, WIC, early intervention, mental health folks, some of the folks on legal services, family supports. And that's been a tremendously important part of all this, and very active, and they're very engaged in trying to make this work. They all see that we all live in silos and everything is fragmented, and even in a state like New Jersey, that's, like Heather said, very rich in services, those services are often redundant, don't work well. The families are often left trying to figure out what to do with nobody really, holding sway over them. And the primary care practices and medical care is often completely separate from the rest of these groups. The managed care organizations are also part of the partnership council. We also have a separate group out of that council called the coordinating council, which is working on some of the things that Ivy's talked about. We need to have, in this age of worrying about sharing data, need to have the ability to share data. So how to have those business agreements and data use agreements that cross through the school lines and FERPA and all these other different issues that are set up for good reason, but those firewalls make it really hard to truly support the whole child and the whole family needs. We've also been working with 211 in New Jersey, because as we develop this model, we're going to actually provide additional services to some of the high-end kids, but there's all these other kids that are going to need some support. And 211 has been very willing to meet with us to really increase what they offer, to have it be more user-friendly, to have those resources available, to work with practices, to meet with families where they do have some social needs, et cetera, to try to connect with a lot of the families where we find issues but don't have the internal resources to support them. Next slide. So the way the model works is that the goal is to be able to touch all these kids on a regular basis, and having a needs assessment. In New Jersey, our needs assessment is done in a way that we want all of these 140,000 families to actually have the assessment done. Some of the other states are using administrative data to get some of this information. Well, New Jersey doesn't have that kind of administrative data anyway, so we're doing it by connecting, going by from birthday to birthday every month. Those folks with a birthday that month will get the needs assessment. We're not asking the practices to be overwhelmed by having all these people coming in needing to do a 45-minute needs assessment. Our needs assessment takes parts of the SWIC and the pediatric symptom checklists and the CRAFT. We also have social determinant screens, and we've added trauma screens. But we're doing it, again, because we have the advantage of having the dollars from the federal government to do this. We're doing this by setting up a technology, and which we've already have down now. We're just in the testing phase, that families will get this at home on a smart app or on their cell phones or on the computer. Also trying to do it in a way that people that know these families connect with them about this. So we don't want it to be some cold call from the government saying, fill out this needs assessment. That's not going to work. We also have it in 4 different languages. We're still working out the usage, but we think the goal is to have this done, and then that automatically gets forwarded both to the primary care practice office electronically. Again, the need for BAAs and data use agreements, and also electronically sent to our care integration managers, which are paid for by the grant, that are like the air traffic controllers, to bring this information and connect it with Medicaid claims data, and then put those kids into 3 levels of need for additional services. Level 1 being kids that won't need advanced care management services, and level 2 and 3 are those kids that would really benefit by having additional supports. The care integration managers also connect with those families that are in a higher tiered group to make sure that they're aware of what's happening, understand it, buy into it. We're doing all this again through a shared care plan process that's interactive, with families signing on and having access to all that. And then the vision is that as that develops, we'll also have the ability to connect with all the other folks that are working with that family, and make sure we actually are working together as a team, not having 5 or 6 different agencies independently working, often at odds with each other rather than in support. Hopefully, eventually the families will be empowered to take as much of this responsibility as they can, but that's not, we don't expect that to happen from the beginning. So the next slide. So I talked about the care integration managers. They are actually paid for by as part of this 7-year grant. I'm not sure what happens when that grant runs away. But the advanced care management team, which we're organizing, which consists of community health workers, social workers, child life, family support people, that's being paid for by an alternative payment model that Medicaid has agreed to do. Medicaid is a partner in this process, so they are at the table with us. And as part of their waivers, they've gotten approval for an alternative, this advanced alternative payment model that pays for the care management services. The hope being that there'll be less cost, less ED visits, less hospitalizations, less out-of-home placements, et cetera, to in the end make this somewhat budget neutral or at least cost effective, and that the alternative payment model also gives the doctors more money for being able to take that needs assessment and work with their families to help deal with some of their needs, particularly the families that don't rise to the level of needing the advanced care. As I said from the beginning, this is a very aspirational model. We don't expect this is going to get off the ground fully in January of 2022. We'll have 5 years to work on this. We're going to start slowly in one county and then spread to the second county. So it's going to be quite a work in process over the next few years. There's a lot of technology built into this. The first bullet on this slide discusses what's called this interoperable electronic platform, the vision, and it's not going to be ready for prime time anytime soon. But the vision is that we're going to have a community platform where data from the schools, IEPs, WIC data from the CMOs, mobile response, all that data is actually on a platform that the family owns actually, and will say who can share that data or not. But as they share it with other agencies and with their medical home folks, there's a chance to have a real richness to real-time information to help inform decision making and care plans and care coordination going forward. So that's the vision of this interoperable electronic platform. There's been a lot of work done nationally around this idea of this sort of platform. We're also we do have in New Jersey a health information network that does have regular on-time data about admissions and discharges, and that'll flow into this also as a way of giving us more information. Next slide. So as part of all this, we from the beginning have felt that this is only going to work at the practice community, not just primary care, but the children's hospitals and the specialty docs, or not just understand what it is, but fully support it and engage in it. So some of it is just education. We've had a series of webinars and some MOC activities, but we've pretty much hit on this kind of an academic detailing, this pediatric office visits model. We think one of the problems with webinars and MOC is that it only hits a few people, and usually only the people that are already excited about this. All the other docs seem to kind of stay away. So our goal has been to try to actually have folks out of the New Jersey chapter of AAP connect with particularly with the high Medicaid practices, get to know the office managers, get to know the folks that work there, to see how we can work with them, not just to have them understand what this is, but have them transform some of the ways that they provide care, particularly around things like shared care as a plan, about care coordination, about community involvement. Then we're going to use some of the tools like the PICS that Heather has talked about as a way of trying to connect and do surveys to see how this is actually working out from a QI measurement process. We also already have in New Jersey the Massachusetts model of pediatric psychiatric collaboration. So that's ongoing as a way of providing that kind of support to the practices for the mental health component of the kids that show positive on the needs assessment screening process. Next slide. I think that's the slide. So anyway, so right now, as we enter the last couple of months of our planning phase, we've made a tremendous amount of progress, more than I would have imagined, considering that New Jersey was back in the 1960s or 70s in many ways in terms of the way care has been organized. A lot of services just very siloed, not connected. Medical care pretty much fragmented from the other services, certainly fragmented from mental health services. So there's been a start. Medicaid's been great to work with. They've been fully involved and invested in this. So this works. They hope to make a lot of this be a statewide process. They've already committed a lot more dollars from the legislative group to pay for this alternative payment model approach. So a lot of challenges ahead. We're not blind to the challenges, but pretty good progress to date.
Thank you so much, Steve. That was awesome. And I've had the pleasure of having some one-on-one meetings with you guys and learning all about the process that you are building out, and just to see the progress is really awesome. I have some questions, but I'll save mine for a little bit and see if anyone else has some questions or comments for Steve. We have about 6 more minutes in here together.
Stephen, I just wanted to say thank you. That this, what you talked about is kind of what we're thinking about doing, but within our health system, working with our Medicaid folks. So I may be connecting with you.
That'd be great. We'd love to have you connect with us. We have a lot to learn ourselves. We learn every time we talk to somebody else. So that would be wonderful. This is, this is all about all of us, scratching our heads and figuring out. We have the luxury, obviously, for having some additional dollars, which it's hard to do without those dollars, particularly the technology pieces. But yeah, we'd be happy to connect with anybody.
Okay, thanks.
Steve, you mentioned talking about like how you guys, the goal is to try to touch, each child to see how they're doing and make sure they're connected with services. What is that process looking like right now? Has that started or still sort of building it out? Like, is it phone calls? Is it like, what's the process and what is that looking like?
Okay, well, it's probably a 3 or 4 pronged vision. So the first is, as I said, that we want to have this needs assessment done every year for these 140,000 kids. That's the feds expect us to meet at least 80% of that vision as part of their metrics of tracking us. But we're also, the goal is to do more than that. For the kids that are in the higher levels of need, we want to have that needs assessment done at least twice a year, particularly like the kids are in the highest level of need, those kids that are always in the ED, always in the hospital or at risk of placement, involved with foster care, etc. But we also want to do more, particularly for not just the kids with highest need, but the rest of the families. I'm quite concerned that so many of these kids that are not going to rise to needing the additional care management still have a lot of needs. We've been working with, we're going to start working, haven't started working yet, but with a patient engagement company that has the capacity to have smartphone connectivity, so they can send out various notes and comments, kind of based on how we program it and what those families have as needs, in a way that's very, very personal. It's not as like, some large company mailing out. It's very directed to that individual person, with a chance for them to trigger back if there are issues or concerns that can come back to us electronically. And I think that's this particular technology is really quite, it's gotten pretty advanced. Of quite a number of other organizations, some of the cancer groups, et cetera, are using it. And I think it's a great way forward, but you're never going to have enough personnel to manage this unless there's a way of connecting electronically. So that patient engagement technology is something that's on tap for next year to work out and get ready for year 4. But that's to us one of the approaches of making sure we have that connections.
That's awesome. It sort of reminds me when I was helping build out a care coordination program in an adolescent and young adult practice. We specifically asked the patients, how can we connect with you best? They're missing phone calls, they're not showing up for appointments. And they're like, if you send me a text, I will answer. And so we're like, okay, we need to figure out how we can get secure texting. And so we'd actually figured out a way to incorporate in some of our funding, some cell phones for our care coordinators. And we're able to have a secure message of, able to text them, and they were answering. And that was, how they wanted to do it. They don't want to talk on the phone. They don't, they were at times we could get them in for appointments if we would text them the visit information, and that's how it worked. And it just was us, saying clearly what we were doing was not working when we were trying to call them nonstop and, booking appointments. And then once they said that, it was really awesome to see, I'd send a text and they would answer, and I got really excited. So it's kind of figuring out, the best method to connect with the group that you're trying to serve.
Yeah, no, that very much works. And this particular technology goes even a step further. It's not just, how you kind of reaching out to a few folks. It's the ability to have, for example, I know in New Jersey, that one of our local oncology groups has this technology, and they are regularly sending out notes to their cancer patients about, maybe you just want to see what's happening in this arena, or where are you going, how's your day going, but with very specific messages based on the particular issues. And then always these triggers that if they raise issues that are concerning, they come back to someone kind of monitoring the process to then alerts the clinical team that this is a person that needs a phone call, or it needs a connection because something is happening that needs to get dealt with. So it's a great way to touch a lot of people without, again, having to worry about old approaches of phone calls or emails, or those things. It never worked, and they certainly don't work in today's world. So.
Awesome. So I think we're about to close the breakout rooms, but there's one last question I wanted to get in. Was just asking Steve, is the screening completed automatically in the EMR? Or is it manually screening completed by the care team?
Right. So the needs assessment, as I said, is done by an app. So there's an app that we've organized that we could, when it's prime time, I could certainly share with Heather, that goes. It's very easy to use. It's got pictures, and it's in 3 or 4 languages. It goes directly to the smartphones or computers of the families, directly to their homes. And then as they fill it out and send it back, it automatically gets sent by the system, both to the primary care doctor, to their either electronic records, or to their just their email addresses to get incorporated into their EMR, and then also gets used to help define the levels of need for additional care.
Thank you, Steve. Well, I hope everybody had a good time. This was really fun. It was really nice to hear about all your models and your successes and challenges and how you overcome them. What we're going to do now is we're going to head back into the main room. So I'm going to close the breakout rooms, but we're going to head out to a break until 1:55. So feel free to just return to the main room and then go on your break and come back at 1:55 for the discussion, please. Excellent. Well, I hope everybody had fun at the breakouts. I really loved listening to all the presentations in the care model group. Be very interested to hear in the discussion today how the other groups had gone. And so just a reminder of some of the discussion questions that we hope to talk about today. Before we went into the breakouts, these were the couple items that we wanted you to be thinking about. So we'll be asking you, what did you learn and what will stick with you? What team did you learn that from? And then if there's any strategy or tactics that you might apply to your program based on what you learned. So I'll start off by kicking things over to Rich to start us off.
Just start with a simple wow with about 6 exclamation points. That was just an amazing session. The way that we're going to organize this discussion, and I want to make it clear to everybody, we're not simply going to just do a summary of the high points. I've tried to, in essentially real time, curate a list of both interesting points and some challenges that I think are going, that I'm confident will be meaningful for each of the groups in our shared journey. So that's the framing for this. With respect to each of our 4 teams, if there is another highlight that you'd like to point out, that would be great. But I would like to frame it that way. So the first team up was this spina bifida team from Pennsylvania, from Penn State. And we've got Sierra Smith did a just spectacular job of a succinct presentation, gave us lots to think about. So Sierra, why don't you give sort of a very high level summary of those points? And then I'll have Judy Thibodeau and Mary Farrell in the on-deck circle to make your points.
Thank you so much, Rich. So my team has done the FESAT. We did 4 people completed the FESAT. 2 were staff members and 2 were patients of the clinic. And then the clinic team went on to distribute 40 questionnaires from the PICS that were completed by patients and family members of the clinic. And a big thing that we realized, that the team realized, is that there is a lot of work that needs to be done within transition from pediatric to adult care. Hershey, or Penn State Health Hershey, is one of the few spina bifida clinics that caters to both the pediatric and adult populations. But there is still some struggle with the transition of going from pediatrics to adult care, with, you know, who follows their patients, who are the new people on the team, how is that handled within the clinic, and things like that. So that was what we discussed as part of the Hershey team.
And Judy, if you could give us a perspective, but take a minute or 2 to frame who you are and why you're sort of the structure, if you will, because you are a unique team to this Care Coordination Academy.
Thanks, Rich. And we're glad to be part of the Academy. I'm the Director of Research and Services with the Spina Bifida Association, a national organization that relates to spina bifida clinics and adults and chapters in this country. And we have 10 standards that are really, really important, and by which clinics can become partners with us. And 3 of those standards, care coordination, transition, and family councils, are very relevant to this work. And I just want to comment that Sierra Smith is actually a member of the family council at, they call them the PFAC, at Hershey. So you're really getting a person with spina bifida's perspective on this work. So we are learning and hope to be able to model from this work with our clinics, and there are other spina bifida clinics involved in the Academy, how to take this broadly to our other clinics who struggle. They all have care coordination, but that patient integration piece, the part that facilitates transition, the care coordination piece is not easy to implement or to even understand in a financially challenged, personnel challenged clinic. So we really appreciate this opportunity, and I think we're sticking with it and learning as we go. The second year is, I think, going to be the most beneficial of all to us. So thank you.
Thank you. And the teaching point, folks, is really, here you have a clinic sitting there at State College, similar to the one that you're going to hear from momentarily from Cincinnati. But there's, if you will, an organizational structure over them that's not defined by state boundaries, but in fact by the dedication to, in this case, spina bifida. And there are other organizations, I'm thrilled to say, but not at liberty to announce which one, another North American organization focused on a particularly complex population, reached out last month and want to do the same thing. And so for those of you that want to begin your work in a clinic and then scratch your head and say, but how do we get this in front of Medicaid? How do we get our own CEO inside our enterprise to notice us, et cetera. So we're trying to build this matrixed community to get the word out. And so I'm going to make a couple of observations about transition, but Mary Farrell, your experience is profoundly important and of value to the rest of the academy. So I'd like you to offer a couple of comments, please. Are you on mute, Mary?
Hi there. Yes, I had to answer. I was on call, so I had to end up doing some clinical work for the last few minutes. So I guess I just really wanted to address the issues with the transition from peds to adult spina bifida, is what we had talked about during our session. I think some of the issues that we've run into, I don't think from what I can determine from the model that we've used, that the pediatric model necessarily translates across to the adult model. I think part of the reason being is that the adult issues are somewhat different than we have encountered for the PEDS program. In other words, you have the urologist, the PEDS ortho, neurosurgery, GI, nephrology involved. But I think as the patients transition, what we've discovered is that their issues are just a little different, and maybe the model should be a different model as opposed to the multidisciplinary pediatric model. And that could be where ortho are not, a lot of their issues may be more stable, and that PM&R is really more valuable, I think, to the adults maybe than it is to the, not necessarily saying it's not valuable to the children, but it seems like PM&R seems to be, needs to play a bigger part. I think the other part is the issue of sexuality and involving GYN, particularly for the female patients with spina bifida. Urologic issues, I think, continue to be also an issue as we transition across to the adult services. And I think a lot of the times with the neurosurgery, they're certainly more actively involved with the children, but maybe less active with the adults, where a lot of times their shunts are more stable and they're not needing maybe as much interventions as the children do. So I think looking at the models of care could be a little different. In terms of the multidisciplinary clinic, or if that's the multidisciplinary approach to the adult model, could be PM&R, urology, GYN, and perhaps neurosurgery on an intermittent basis. I think one of the biggest things that we see where, we're a children's hospital under the umbrella of an adult hospital, where you would think it should be really seamless care, that it should be easy to transition across within the same system. But the biggest, I think, hurdle that we've encountered is the Medicaid for the adults, which some of the adult services are not accepting, and that's become a problem for us.
Thank you, Mary. And so I want to, the reason I wanted to honor Sierra's bringing out this notion of transition is I'm sure there is not a team in this academy that isn't thinking about this. But as I mentioned to you, we were trying to pick out observations and experiences that are relevant broadly. And we're doing some work now that's actually moving into expansion mode in the Boston area, transitioning young adults and adults with complex needs into adult care. And guess what we're doing? We're using the same tools that we're using in this academy: action grid, care coordination measurement tool, the PICS instrument, et cetera. So for those of you that are trying to build a project that eventually optimizes safe, equitable, high quality and sustainable care transition to adult care, using the same tools works. All right, I'm gonna pivot to our Cincinnati discussion. Janetta, if you could give us, in particular, I think it was really great, the work that you talked about that shared the family, active family engagement. And then I'd like to be able to have, in fact, Judy, to save time, you've already described the SBA, so I'm gonna, you won't need to jump in, but Annie, I think your observation about promotion more broadly is relevant for this conversation. So Janetta first and then Annie next.
Yes, so I'm Janetta Thomas, one of the nurse coordinators from Cincinnati Children's, the Spina Bifida Clinic. And we have completed our family engagement study. Currently, right now, we're in progress of instituting the care coordination management tool. So my role, and then there's another nurse coordinator for our clinic. Our roles are supported by Title V funds, and that's just for children within Ohio. But we do provide care coordination activities for all children for the states that we see patients: Ohio, Kentucky, Indiana, Tennessee, and West Virginia. So that's our goal for using their care coordination management tool, just to kind of quantify our care coordination activities that we can use and take that information to our divisional leadership and request more resources and support. And then also we can maybe use it as quality initiative improvement efforts in the future. But definitely we'd like to kind of quantify and say the reason for doing our work for all children.
Thank you. And then Annie, your observation that had implications for spread and engagement.
Yeah, so Janetta had mentioned just getting people excited and familiar with the tool. And so we just shared that at CHOC, we implemented the care coordination measurement tool ourselves. And we used the 2 articles that are in Open Pediatrics that the Care Coordination Academy provided us, just to show how useful the CCMT is. So there's one from cardiology at Boston Children's, and there's one from, I think, Oregon infectious diseases that were helpful. So we shared those with the staff that we asked to use the CCMT so that they could understand where we were coming from. And then we also really emphasized to them not only the benefits to our patients and families, but to themselves. So how can we identify gaps in staffing and help you to feel better supported in the work that you do? And then the last thing is we used Heather's idea to do the save the dates. So she had recommended like early each morning when we're doing the care coordination measurement tool to send out an email, like saying, this is the day that we're all working on this, to get people excited about it.
All right, thank you. And in fact, to manage time, Annie, why don't you and Karen, so now we're frame shifting from our 2 spina bifida clinics into CHOC's presentation. And then Michigan, you're in the on deck circle. So Annie and Karen, however you'd like to present that. And I'm not even going to share the word that is delectable. I'll let you guys have your own thunder.
So I'll let Karen say the delectable word. But basically, we wanted to make sure that we were validating the tool so that it was meaningful to the staff, particularly at CHOC. So Karen, I can't see you on my screen, but I know you're there.
Yes, I'm here. And the delectable word is CHOCify. So what we did was we took the work that Dr. Antonelli and his team did with the care coordination measurement tool, and we just made it our own. We had to make it relevant to what we do here at CHOC, and that's what we meant by CHOCify.
Yeah, so when we did the clinical scenarios that we shared with expert staff to validate our tool, we basically used real life scenarios. We didn't use actual patient names, but we used actual scenarios from patients that we take care of and made sure that all of the details that they were looking at made sense for what we do on a daily basis. And that helped to inform what changes we needed to make for the tool to make it our own. I don't want to monopolize the time, Rich, but do you want me to say anything else?
I'd like you to talk a little bit about the, why CHOCify and how that relates to the QI. I think that I also know that you guys are doing a lot to build team sense of mission and purpose, which has huge implications for this academy. And then finally, I know that Carolyn Allhouse didn't have a chance to ask this question, but if you guys could specifically address the family engagement and family partnership piece as well. So those are the talking points I'd like you to bring out. And then Michigan, you're next.
Okay. How about we address the question that was in the chat first? Thank you for reminding me that. And correct me if I'm wrong, Rich, because I know that you kind of invented the CCMT, but Our viewpoint is that it's mainly to look at what we're doing and how to analyze that and how can we identify gaps and better integrate what staff are doing. So it's not it's not to say that it's not family centered, because the answers to each question are obviously based on the direct encounter with the family. So when we say, you know, these are the needs that were identified in this particular encounter, the needs are driven by what the family wants. So it is inherently family centered, but the core of using the tool is looking more at staffing resources. Would you agree with that?
Yeah, absolutely. And that's why what Mary Farrell did in Orlando, her tool may not look like what Janetta's did or yours in CHOC. And that's why it has to be organic. And I'll say one thing about the Medicaid piece. The Medicaid medical director is not going to really care what's actually happening minute to minute, hour to hour amongst the team. They're going to be looking at outcomes. And I'll put in the chat how these things align. But I do think that each of the presentations, and in particular setting the stage for Michigan Next, is exactly where we need to go. Can you distinguish, Andy, just last question for you and or Karen, the difference between using CCMT data in QI versus formulating a business model for value capture and sustainability? Is CHOC far enough down the road yet to be able to share some experience with that?
Well, so we're at an interesting time right now, and in terms of the data, we really just got all of the data analyzed right before this. So our next step is we have a meeting set up with all the leaders that were involved in this project to share with them all the data. And then we want them to go to their respective groups, so social work, nursing, and then our lay groups, patient care coordinators and care management assistants. Go to them with the data and find out what they think are our strengths and opportunities and gaps, and then go from there as to what next best steps in actual, practical steps, what we're going to do differently. Because I think there's a lot to learn from looking at what others are doing with mutual patients and how we can streamline that process better.
Yeah, that's perfect. So let's pivot now to our fourth group. Marcia, Teresa, and or whoever wants to give us a quick summary, high-level summary, but these are the points that I'd like you to be particularly reflective on, because I think it'll be of interest to the broader academy. Differentiation between their care management model and say payer-based case management. I love the discussion about establishing and cultivating new and additional partnerships, and the use of the term benefit is an important concept when one is thinking about Medicaid and CMS, because there is an opportunity down the road. So if you folks from Michigan could share those points with the rest of the academy, that'd be great.
Thanks, Rich. So I'll just give a quick high-level snapshot here. Our pilot program is out of CS Mott Children's Hospital, and it's called Partners for Children. So we've been partnering with them to learn from their model, which was modeled after the California Partners for Children, and is actually an intense care coordination program. What makes it unique is that it has a home visit component. The family has access to the multidisciplinary team 24/7 for urgent needs. And they essentially are maintaining or using real-time care planning with the family. So it's a very intimate relationship between the care team and the family. So one of the things that we are looking at when we're proposing establishing this as a benefit, and I'm using air quotes, is that it is different from existing case management programs, whether it's through a payer or other programming, possibly, because of the facts that the characteristics I just mentioned, that it is a home-based program. It's a unique team-based approach using, in this case, a nurse practitioner, social workers, and physicians. And having that access 24/7, which we've seen in patient profiles they've shared with us, that having that access is critical in understanding when the family has a situation that by involving that team right away, they oftentimes are able to avoid ER visits, or if they do need an ER visit, the team can call ahead and make arrangements with that ER to speed up, admission and so forth. Teresa, do you want to jump in and respond at all to any of the other points that Rich mentioned?
Sure, I can do that. I think when we talk about a benefit from a Medicaid standpoint, we're talking about a service that's going to be available. And so the models that we're looking at right now is a home health model, which would be then available to anybody who would fit within that target population. And the home health model is specific in that there are 6 different types of services that should be provided, which include care coordination, case management, health education, transition care, family support, and then I think referral to community-based organizations. So that those 6 elements are key to the services that need to be provided. And so I think one of the challenges that we face as an organization is to think about the fact that Michigan already pays for some of these services on an encounter basis, meaning that a person presents, the provider provides, the bill is submitted. And so what we're thinking about needs to occur in order to address some of the quote unquote, and again, using air quotes, hidden costs of care coordination is to think about what is the information that we need to support the idea that perhaps this needs to go from being an encounter-based to being a member per month kind of a reimbursement. And so in Michigan, we're very blessed to be able to have different types of care coordination providers. If you're in CSHCS, you receive a care coordination benefit through your local health department. If you are engaged in a Medicaid health plan, then you can have some care management services that way. And so what we also need to then identify is how does this unique set of services, the set of more intensive care services, actually translate to better care, and then of course also translate into some kind of either cost benefit or cost savings, or at least cost neutrality. So I don't know if there's anything else you'd like us to share.
Well, I'll close it, and then I want to make sure we get to the other groups. What I really like about Michigan is you've done a great job defining the population. You're doing a deeper dive now, articulating what these activities are that would support this focused care management model. One of the quotes that I especially liked on one of your slides was, and how does it connect with existing delivery system infrastructures? That's not a trivial point. In fact, does that mean all of a sudden families don't get to stick with certain members of their care team? That's not a challenge for Michigan, but I just want to let people know that these are critical issues going forward. So I'm going to hand it over now. Is it Jeff or Heather that's following me?
I can go after you, Rich. Thank you.
All right,
and then Jeff
take it
will
away.
go after. Thank you. So I had the care model group, and the teams that I had with me were Montana, Minnesota, Kentucky, and New Jersey. We had really robust conversations, and it was awesome presentations. The way I want to style our discussion portion is I'd actually like to open it up to everyone that was in my group. I'd be curious just to start off. So Team Montana had gone first. Is there anyone that was in my group when listening to Team Montana, anything that stuck out to you, something that you learned that they'd either do differently or that surprised you, and that it would stick with you and something you might bring to your own program? If anyone wants to jump on.
Yeah, Heather, I'll mention the family grand rounds that were mentioned were very unique. That concept was just completely new, a new idea and a new concept that I thought was very intriguing. So
Yes, I think that was a big hit that we were all very interested in. Mackenzie, I don't know if you're still on right now, but do you think you can give a quick, like, high level summary of the family grand rounds? And I think Linda, who helped coordinate that, had to jump off, but we can definitely give her credit for all of that organization.
Yeah, so major props go to Linda for helping facilitate. In coordination with Kim Brown, who co-leads our Montana team, and Ali Rive, we worked with 3 parents who represented pretty diverse experiences and diverse conditions of their kids within our system here. And we basically just had sort of like a question and answer panel where we primed them around questions related to their experience in the healthcare system, like what worked for them, what didn't work for them. One parent could speak to, the exact type of provider who makes them fall in love with them. So there's a lot of positives around, like, this is what really worked for us and our family. And there's also some real sort of direct feedback around, practice changes and practices that could be made to support families, like such as wait times and things like that, depending on how well, the child is able to kind of manage in some of the settings. This was the first time we had ever done a grand round, and we reached out. We have a university that organizes them. It's the first time they had ever done a parent panel before. And so we received some pretty positive feedback from some providers who attended, as well as some university center stakeholders who are actually facilitating other work in the community around mapping our early identification system. So I think for us, it's been very powerful and positive, and it's also made us think more about how we can continue and also tailor these different topics within the healthcare system, as well as different stakeholders, such as public health, Medicaid, other types of systems that our families are often engaging with, but always incorporating the family perspective.
Thank you, Mackenzie.
This is the other Ivy from that group. All the presentations were really wonderful. And regarding the grand rounds, I think that they are going to provide the template that can be shared with the Care Coordination Academy. Did I get that right?
Yes,
Yeah,
we
so
will
Linda
work on that. So sorry, yeah.
That's something to look forward to see that and possibly replicate it.
Yes, yeah, Mackenzie, once you guys have that prepared, if you want to send it over to me, and then our faculty group can review it, and then we can disseminate it so that other practices and organizations can look into doing a family panel, which sounds like it was such a great opportunity. Anyone else from my group, when listening to the Montana team, anything else that you learned or that stuck with you, or that was similar to sort of some challenges and things that your team was going through? I know one big thing, a very common theme that we talked about in my group was geographical challenges, specifically with Montana and Minnesota, having some of these facilities, 6 or 7 hours away for families. Rhonda from Minnesota, do you want to talk a little bit about some of the things that you guys do to try to overcome those barriers?
As Nick suggested, we do not provide dog sleds to the people in northern Minnesota to get to care. But what we have tried to do is, so families that are seen in our complex care program, they have, simplest terms, a dedicated scheduler. So it's somebody who can, because our system is specialty only, it can schedule appointments the way the family wants. Sometimes they're all in one day. You're at the clinic for 8 hours. Sometimes they're spread over multiple days. And then our social workers kind of work with the families to find lodging and to help pay for that. Transportation is always a challenge, especially if you live far away and don't have a vehicle. But again, the social workers work with that. Virtual care has been a godsend for everybody living in greater Minnesota. And hopefully it won't go away.
Thank you, Rhonda. I'm going to keep you up here because there was something else that I think a lot of us started talking a bit with your group as well about. You guys have a large Somali population and trying to assure that sort of your family liaisons kind of represent that culture, but it's been challenging to have that. Do you want to summarize that a little bit? Because I'm sure there's other teams out there that also have, different cultures, and it's challenging to be able to find, someone that's not just an interpreter, but that can actually inform care and be part of the program. Do you want to speak a little bit about that, please?
It's just really hard. We haven't landed on anything good. I mean, we're now back to, as was recommended by Glenn Gabar almost 2 years ago, to doing some focus groups with the families. One with our Somali population, one with our Spanish speaking population, the other with our Hmong speaking population. And just to understand what are their needs, what are we missing? And ideally from that, identifying several parents that would want to join our advisory group. But it's hard, the challenging part, because we've tried to build relationships with the community. It's really hard. It's hard.
This is Ivy, and I attended that. You said something, Rhonda, that really stuck with me, that explaining or communicating to a large hospital system that only having an interpreter is not sufficient or meaningful engagement. That really resonated. And so I wonder how we can go in any population, maybe where it's easier to build those relationships. Is an interpreter not sufficient and not as robust in supporting care coordination as, as a navigator, as a thing? I have another comment about your presentation, but please respond to that. Thought it was really powerful.
So I think Tricia, if you're on, Tricia's the one that brought that up, but that is key. I mean, an interpreter can only interpret. It's getting at the nuances and the culture. There's just so much more.
Thanks. The other thing that stuck out was that you're going to be doing a time study, both for providers and parents, in an effort to build a business case for care coordinators, for care coordination, and maybe in particular, parent navigators.
Yes, we're going to be using a kind of a customized CCMT. And again, not only for our clinicians, but also for parents. And the data collection from parents will be done by interview format. We're not going to ask them to fill out a spreadsheet every day because our parent advisor said that will not happen. So it'll be by interview every week to 2 weeks, but we'll just kind of talk through. And actually, Anne, I realized that what is not focused on that is the outcomes of the activity. So we need to add that back for the parents. What would the outcomes, what was the outcome of doing that activity?
Thank you, Rhonda. Your presentation was excellent. I'm going to jump to our next group, which was Team Kentucky. I have some common themes that I had pulled out of the presentation, but I want to definitely open it up to the people that were in the group. If there's any comments or things that stuck with you from Ivy Alexander's presentation that you want to share, I can give you guys a moment if you want to pop on. All right, you can jump in at any time, but Ivy, do you mind just sharing a little bit about the program that you guys have that allows for the shared plan of care to sort of be electronic and be readily available and updated in real time?
Yeah, so one of our goals is we have a system that's developed in-house that has a lot of data in it. And before patients are discharged, there's a report that's printed out that's given to the families. okay, their care, regarding their care. And so we want to really create a true shared plan of care, enhance our shared plan of care, utilizing that system. So
so when you mentioned the goal would be at one point to be able to have the families have, like right now you're printing it out for the families, but a futuristic goal could be that families can log on just as a provider could, and be able to access it in real time and be able to even help edit.
Correct. Yes. Yeah. So with our system, again, it's developed in-house. Originally, the system was only available to employees, those that saw patients and were interacting with families. And then our providers, so another subset of it was now the providers can actually get to their provider information no matter where they are, or their patient's information. And so the patient or the family having access is also on that list, on the checklist to have accomplished as well.
Great, thank you. And then one of the other themes sort of throughout all of our groups, but specifically something that Kentucky sounds like they're focusing on, is the expansion of mental health. I think we're seeing another pandemic pretty much after COVID for adolescent and younger children and young adults. Really every age group right now is the mental health need. Can you tell us a little bit about some of the steps you guys are taking to expand your mental health programs?
Yeah, so currently our focus for care coordination is specifically to the clinical specialties that we have. And we're a Title V agency, and we're part of our partner in that is public health. And public health has received grant funding for pediatric mental health care access, where they are essentially training providers on how to refer and structuring referral sources. So we'll be involved in that process to refer out to those providers when needed, if needed, for the kids to come to our clinics.
Great, definitely very much needed. We look forward to hearing how that process goes. You can continue to inform us on recommendations for doing that as well. So I'm actually going to jump next so we can make sure we get to the funding group as well. But our last group was the New Jersey Inc. team that presented, and they have an awesome model that they continue to build out. Steve, do you want to pop on a little bit and just talk about kind of the needs assessment that you guys are going to be implementing and what that looks like?
Yeah, sure, Heather. So thanks. Yeah, so this is a little bit different than the other approaches. This is a population-based model. It's not really directed towards one clinic or one health center. It's meant to cover a whole population of kids who've received Medicaid, in this case, a couple of counties. So part of our vision is to touch all these kids on a regular basis, and then to, based on doing that, be able to assign those kids that need additional support to get that support. So that's the kind of the concept, and the way that we're touching all those kids is a combination of Medicaid claims data, kind of like what Washington, Oregon have done, but also actually a needs assessment that uses evidence-based tools like SWIC and pediatric symptom checklists and some social determinants screens, and even some of the trauma-based screens, and to have the families fill it out. We know that that's not going to happen in pediatric offices on a regular basis. It's too unwieldy. So what we're working on is actually an app, technology driven, an app that hopefully done to a warm handoff with folks that these families know, so it's not coming in from a cold source. The app is available, will be available on their smartphone and on their computer, and they'll have a chance to fill it out at their leisure when they can come to it a few times or more, depending on how long it will take them, or all in one sitting. And then when they fill it out, there's always a chance for them to opt out of questions. That's up to them. Then it'll automatically be sent to the Inc. team to be used for helping to assign levels of need of extra care, and also go directly to the primary care medical home. So they'll have that available to them. The goal is to send it to families before their birth date so that they'll be ready for the primary care practices when they come in for the well child visits. So that's the general scheme of what we're trying to do for that.
Thank you, Steve. It's a really great model. I look forward to hearing how it continues to unfold. I'm going to pass things off to Jeff Schiff now in the funding sustainability group so we can hear some of your discussions.
Thanks, Heather. There's a phrase that we use in the Medicaid Medical Directors Network, which is share and steal shamelessly. So I think we ought to adopt that for this network. I wanted to maybe I'm going to do two things. I think first, I want to ask anybody who was in the funding group if there was a theme that for the people who were listening, if they wanted to bring out. And short of that, I think I'm going to go by theme here, because there were some incredible themes that actually I think often crossed over our three presenters, which were Texas, Florida, and Indiana. So to the people who are in our group, any themes that you're going to take home and, tomorrow you're going to tell to somebody else in your world and say, that was an amazing thing that Texas, Florida, or Indiana is working on.
I'd like to say that I really like the aspect of taking siblings to the appointment as well, to incorporate the whole family, even if they didn't have different needs. And I never really thought about the aspect of asking the state for special permission to execute certain parts to make sure that the payees get their I's dotted and their T's crossed, but then also make sure that the families and the clinics get what they need. It just never dawned on me to ask for that, and I think we should do that more.
So I thought the siblings was very cool also, because it was basically saying we're going to, and I think that was, I'm sorry, I'm looking at my notes. That was Florida's, and I thought it was really a great way to make sure we honor the families. Adnike, do you want your second point was about, say it again if you don't mind.
Well, I think it was the second team. They said that the first team, they said they asked for special permission from the state to execute parts of the plan that didn't line up with all of the bureaucracy that we have, why the clinics cannot execute the way that they want to. And I guess I never really thought of asking for special permission, like for the clinics asking for that special permission to say, well, I know you're not reimbursing us for this, but if we do this, will you do this for us? And I think the fact that they actually did that and it worked was kind of something that sat with me.
Yeah. So Adnike, I hope I'm saying your name right. I wanted to, that was actually one of the first points that I thought of that was common across a lot of our presentations, was this idea of that, but also about sort of how it happened, because Texas and definitely Indiana, and I think evolvingly Florida, all had a payer at the table through the whole thing. And maybe I'll ask Kevin from Texas to jump on just to talk about the amount of commitment that Blue Cross and Blue Shield in Texas has to this program. It's on an ongoing dialogue. Kevin, are you still with us? I guess he's not. So I'll just, and Kendall, I don't know if you want to jump on and say something too, but they met. Kendall, are you here?
I am here. I am. I didn't look to see if Kevin was still on or not. I don't know if he's muted or not, but I'm happy to comment. As far as the involvement of having our managed care organization on board has been just absolutely essential for our success. And we actually have experience of having partnered with another managed care organization earlier in our career as a complex care clinic. And we didn't have the same commitment from leadership all the way down to boots on the ground of meeting on a regular basis. So our expectations got sideways, our deliverables were not the same. We were looking at outcomes that were not in line with what the MCO was looking for. And so inevitably that project was actually stopped short. So we took the learnings from that experience with that MCO and then went forward with Blue Cross in a very, very different way and had much more success.
Great, thanks. And I just want to point out the time frame, because I think what Kevin did say, and I wrote this down with a little star next to it, is meeting every 2 weeks for 2 years. And then I think the other thing that struck me was Kevin was honest and said he needed to socialize the model inside Blue Cross and Blue Shield. So having an advocate there was really important. And I think that the other two teams, and I'm not sure if Kristen or Natasha want to jump on, but the other two teams have started to have some of the same dialogues with their Medicaid and Title V at the state level or with the managed care organizations. Either of you want to comment on that? Okay, it's quiet. I want to ask about, I want to then move on to maybe another theme that I think both that all three of them looked at, and I will call on Natasha and Kristen about this. Both of those teams actually spent, I think, a lot of time talking about how to measure, and I think Texas as well, how to measure the family outcomes of the care coordination models they had. Natasha, will you talk about how you guys were doing that in Indiana, and then maybe I can ask Kristen to comment on that in Florida?
So we are you're talking about the measuring family satisfaction.
Yep.
Yeah. So we are using the family satisfaction survey that we implemented with the CoIIN, and have just been continuing that for kind of biannual cycles, and seeing how our strategies on educating about, our shared plans of care and care coordination and how that impacts the family. We have seen an increase in, knowledge and satisfaction with those two things in particular. So that's kind of how we're using that.
I also want to point out that Indiana has this graphed over time. So it's kind of nice to see the improvement or the progress in there. And then I don't know if Kristen or Kendall, I can ask you. Kendall, you had your three different aspects of measuring for the family, and I wonder if you could just mention that a little bit.
Yeah, sure. So I had mentioned a model that Elizabeth Teesberg and Scott Wallace had developed, and they're the model measures patient calm or family and patient calm, comfort, and capability. And at each of those sections, we have developed an evaluation tool of how it is that we are asking questions of our families, how close we got to the mark on those. So in particular, the calm one, our family work group has been the most involved in developing the outcomes for that. And it speaks specifically to, have we reduced your level of stress? Are you less isolated? Do you actually have a shared plan of care? Do you, is it helpful? Can you access it easily? Does your medical team have a good understanding of your child and your family's needs? So that's kind of the calm portion of it. Capability is much more of a functional tool. So like whether or not the child is going to school, Are parents able to work if they are choosing to do that outside of the home? We also track clinical outcomes within the capability portion of this. And those are just more of your traditional utilization tracking, such as ED and length of stay and hospitalizations or readmission. And then finally, comfort, and we borrowed this from the original CoIIN. Texas had added some survey questions to the family satisfaction survey in general. And so Team Texas had added questions on feeding, pain, and sleep that we ask families how we're doing on that.
Thanks. I think the thing that struck me about all the teams was this emphasis on measurement of how the families are doing, and then some emphasis of measurement on, the nuts and bolts of utilization that can be translated for payers into some financial things, but not some of the process measures of the HEDIS or the core set that we do in between. Another theme I wanted to ask to get picked up on a little bit, Kristen, if you're willing to come on and talk a little bit about the selling point of looking at transitions and how your team in Florida is addressing that.
Right. So one of the gaps that we noticed in care in the Central Florida region, particularly for our most vulnerable patients, is accessing care during the period of transition from pediatric to adult-oriented healthcare systems. One of our observations, unfortunately, is that though patients on paper may have insurance, practically speaking, they can access very little specialty care if they have Medicaid, because most of the providers at the specialty level have a quota for how many Medicaid patients they can accept per month, which vastly limits the access for most of our patients. And what we saw is that our patients and families needed a lot of support during this transition period from pediatric to adult-oriented care, and that's one of the selling points, to use that language, that we use in convincing our organization to provide resources to allow us to build our clinic, because we were meeting such a deep patient and family need during this critical time period.
Kristen, if I could just ask you to comment on, I think something that was common theme in all three of our programs is your organization's footing the bill for part of this right now. Can you talk about, can you just say a little bit about that? And if the other teams want to jump on, they can, but I think it's really the same theme, that it didn't start with, a payer coming on board. It started with the need that you guys identified and sold inside your organization.
I think the need is made clear. Providers see it at every level of care. And the hard part is convincing the organization to put resources behind it. And even if those resources are put behind the need, trying to create new models of measurement in a system that's used to looking at care being delivered in one particular kind of way, specifically in a sort of encounter-based payment model. That's been one of our greatest challenges, because it even goes so far back as to how do you measure your providers if you're used to measuring them against MGMA data for generating a certain amount of RVUs per month? How do you compare a complex care primary care provider to a typical pediatrician who may see upwards of 30 patients in a day? So that's been some of what we've encountered, and it's really taken a commitment to everyone thinking outside of the box, because even in the national language about this, there is not a great deal of standardization around what types of resources are needed to make a complex care clinic work, and how do you measure the effectiveness of complex care clinics in a way that could be understood by the organizations who might be footing the bill. How do you even go and ask for certain resource requests. What are national models behind how many FTE of providers are, what is the patient panel of CMC that should be associated with one FTE of a provider? What is the provider RN care coordinator to patient ratio supposed to look like to provide good care? And so those were some of the kinds of questions that we were grappling with and trying to. There's not a lot of information to lean on as we're making those arguments, except for local data and our own experience.
Thanks. Kristen, I'm going to ask the other two groups who actually gave us some specific numbers around that to jump on and just tell us real quickly, Kendall and Natasha, your numbers of patients per provider and patients per care coordinator that you think that you're working on for the model. Because I think people are afraid to hang their hat on some of these numbers, but you got to do it because that's where it translates to how to get paid. Natasha, or Kendall, go ahead.
I'm sorry, I can jump in and just share that we have 5 full-time providers, and we treat both our pediatricians and our pediatric nurse practitioners exactly the same. They all are primary care providers, and they all have a panel that what we've discovered over time is that probably the largest panel that one provider can handle of this level of complexity would be 250, and that number may be closer to like 225. And then the other number that I'll throw out there is that for each of those providers, they have RN case managers who support that provider. And if you are doing the intensive model that we are with a managed care organization, where we are providing assessments for the MCO, that ratio probably needs to be 1:50 for your RN case manager. If you don't have that requirement, I would expect that you would not be able to have one nurse be responsible for any more than 100 patients. And then we do have other disciplines such as some fraction of dietitian, social work, and child life specialists in addition to that.
Okay. Natasha, do you want to jump in real quick on this?
Sure. So we have 3 primary care practices throughout the state that we're working with, and at those primary care practices, we have 1 nurse care coordinator embedded in each. So we have a total of 3 nurse care coordinators. Each nurse care coordinator has a registry of 100 patients, which gives us a total registry of 300 patients for our project.
Great. I got to give the rest of the crew time to close out. I want to thank our presenters. They were amazing. The work is great. I want to just highlight a couple of things that we didn't get to in this discussion. Texas is working on an electronic shared care plan that is available to the families. We didn't talk about how to define the populations, but I think that that's something that's worth discussing. And we didn't get a chance to talk about the coaching and learning collaborative that Indiana does to normalize the way care coordination gets done in the state. But again, I think this was a wonderful way to spend our time learning from each of you and sharing and stealing. And I hope we can just facilitate that to continue. I'm going to turn this back over to you, Heather, I believe. So.
Thank you, Jeff. So I'm actually going to turn it over to Rich really quick, but then we will all close out together. I do want to mention that Erica Norkis in just a moment is going to post the attendance sheet link and also the evaluation link in the chat. I mentioned before, if your facility does not allow you to access Google Doc, just send me an email and we'll make sure to add you. And you only need to fill out the attendance if you're one of the approved professions to request continuing ed credits. I will send those links out in an email later tonight, and you'll be able to access those for the next couple of days. So Rich, do you want to talk a little bit about what's next?
I would, and then my colleague from Boston University, the CMC CoIIN, Beth Lynn, will make a closing remark as well. So what's next? First of all, I am just overwhelmed. I'm so proud of each of the teams. I'm mindful of that photograph that we saw of Thomas, Charles, Pamela. from looking like a neonate to already standing. Our teams are in different places, as they should be, and the progress is really, really important. Our goal is to have the Academy be one of the many platforms by which you can demonstrate progress. But importantly, it isn't just like, this is important, people should pay for it. This is what the work of care coordination looks like. This is what it feels like. We're willing to show you, to demonstrate what it is that we do patient by patient, hour by hour. And I am just so proud of the momentum that we're continuing to build. So the core faculty will process your evaluation. Please fill out the evaluation for today. We greatly appreciate the fact that you sent those wonderful presentations. We'll use that and then define some priorities for going forward. With that, I'll hand it over to my colleague from the CMC CoIIN, Beth Lynn.
Hi, everybody. I just wanted to say, so I was able to join, I was here the whole time, was able to join in on group 1 with Just Group. And just the CMC CoIIN, we have shifted that we had done, as many of you know, we had done our own quality improvement work, and to see what we're continuing to build on for those teams and the other work the other teams are doing in this sphere. This is work that is very important focus of HRSA, that they want to see the ways that we can bring this together to do that sustainability at the same time as we're talking about that, like the three-legged stool. How do we bring that together so that this work can be infused with and sustained moving forward, and the best ways to do that. So that's the work that you've been doing today, and those grapplings are very real in each locality where you're working, and yet you hear these common themes that you can apply and elements that you can apply. But so I'm just, every time I'm with you and hear this, I feel hopeful for what you're all doing, and hearing how most of that ends up being sustained in the spaces, because it's not, we all know that you're not getting compensated for what you're doing, and this is a very mission-driven work. And I'm just very grateful for it, and for the centering of families in that work too. So just, so we're just very grateful for all that you're doing, and know that this is something that's very key to what the CoIIN's doing in their final year, and also in CMC CoIIN, but also for HRSA as well.
Thanks, Beth Lynn. And so Heather, since you're sort of the maestro here, we'll let you close it out.
Yes, well, I just wanted to say thank you again to everybody. I hope you enjoyed the presentations. It was awesome to hear from you all. I think you really have taken it seriously and became the teacher now. So we can probably be the ones that sit back now. But thank you for all the work that you do and coming together and responding to all of my emails and SurveyMonkey requests so that we can make this day as interactive and organized as possible for you. Please fill out the evaluations, be honest. We can only continue to improve these sessions. So we love to hear from you and let us know how it went. And I will circle back with an email later tonight with the links and to let you know when things will be posted onto Open Pediatrics. Thank you so much. Have a good rest of your day. We'll see you in January.
Thank you.
Thanks, everybody.